Hi everyone. Today let us complete the Pluton audiometry topic. Okay. For starting first topic here will be masking. Basically, now we are talking masking in terms of air conduction. So, why do we have to do this masking? So, when a sound is presented to one ear, okay, that ear will hear. Suppose we are presenting a 60 decibels hearing or a sound level or intensity of the sound to one ear, say the right ear will hear it as 60 decibels. We are not giving any sound to the left ear, but the left ear will hear it as 20 decibels because there is an interaural attenuation of 40 decibels. Okay, so even if you are not presenting any sound to the left ear is taking part in the hearing test, and it will the left ear, the sound that is recorded or that will be perceived by the left ear is 20 decibels. So when the sound is presented to one ear through air conduction route, it gets transmitted to other ear via air. It's not via bone, via air it gets transmitted. During this transmission, there is a hearing loss, there is a noise loss, there's a loss. That is called the interaural attenuation, and it is 40 decibels. So this is the same example we have given. If a sound of 60 decibels is present to the right ear, it is heard as 20 decibels in the left ear. Now coming to one more example. Suppose this patient is having a right-sided hearing loss of 50 decibels and the left ear is perfectly normal. Okay. If you present a 50 decibel sound to the right ear, because there is a 50 decibels of hearing loss in the right ear cannot perceive anything. But because of the interaural attenuation through the air conduction route, 10 decibels is presented to the left ear and it is heard as 10 decibels in the left ear. So this will make getting the result a bit tricky. The patient is having a 50 decibels hearing loss, but on the left on the audiogram he picks up the sound at 10 decibels. At the 10 decibels. Okay, so what do you think? Okay, the patient is having a hearing threshold of 10 decibels. It's not like that. So to prevent the better ear from taking part in the hearing test, while testing the worst ear, masking is done. I'll repeat, to prevent the better ear from taking part in the hearing test, while testing the worst ear, masking is done. How do we do masking? Suppose we are testing the right ear. To prevent the left ear from taking the non-test ear from taking part in the hearing test, we apply a complex noise to the left ear. Okay. So whenever we are testing air conduction, if the air conduction thresholds in between the two ears is a minimum of 40 decibels, we always use masking when we are testing for air conduction. So suppose if the right side is having a 60 decibels hearing loss and the left side is having a 20 decibels hearing loss, we go for masking. Okay, so it should be a minimum of 40 decibels. If it is greater than 40 decibels, definitely you should do. If it is less than 40 decibels, you don't have to do it. Suppose why you don't have to do it, 60 decibels hearing loss in the right ear and 30 decibels hearing loss in the left ear. So there is a difference of 30 decibels. So you put a 60 decibels hearing loss here, 60 decibels sound to the right ear. It will be heard as 20 decibels in the left ear, but he is already having a 30 decibels of hearing loss. So he won't be able to hear anything. But if it is 20 decibels, he will be able to hear something. Okay. Bone conduction, what happens? In bone conduction, the entire there is no interaural attenuation. Whatever sound is applied to the right ear, the same will be heard through the bone, through the skull. The left cochlea also gets stimulated. So there is nothing like difference of hearing threshold at the minimum at which level you have to do masking. Bone conduction, every time you have to go for masking, because the moment you apply the mastoid vibrator and the left ear, both the cochlea will get stimulated. So the other ear will be taking part in the hearing test. You don't want that to happen. So you apply a complex noise to the left ear, to the non-test ear. Masking is done by applying a complex noise to the ear. What happens if there is in a Pluton audiometry? What happens when there is a conductive hearing loss? Okay, in this case, this is not the correct one. Actually, this is the bone conduction. bone conduction, all the frequencies he is able to hear at 5 decibels. What did we say in the previous thing? Between 0 to 20 decibels is considered normal. So 5 decibels is definitely normal. Bone conduction is normal. Air conduction, for the same frequencies, we have to raise the intensity. For 250 decibels, we have to raise it by 40 decibels. 50 decibels for 5,500 hertz. 1000 decibels for 50 decibels of hearing impairment is there. Like that, others also, there is a hearing impairment. That means we have, for the same frequencies to be heard into the air conduction route, we have to raise the intensity by approximately, on an average, 40 decibels. So air conduction has got affected by 40 decibels, because of which there is an airborne gap. There is a gap between the air conduction curve and the bone conduction curve. Okay, bone conduction is normal, but the air conduction has decreased. Means we have to give more sound. That is why there is a gap in between the air conduction and the bone conduction curve. To call it conductive deafness, the air-bone gap has to be greater than or equal to 15 to 20 decibels. If it is less than 15 decibels, we do not consider it as air-bone gap. Examples are wax, meatal atresia, ocular dislocation, otosclerosis. So all these are examples for conductive hearing loss. So in conductive hearing loss, what happens? Bone conduction is absolutely normal. Air conduction has got affected. The air conduction has got decreased, or you decrease, the curve has fallen down from the normal. You have to raise the intensity for the same to be heard. There is a hearing impairment only when it comes to air conduction. So there is a gap in between the air and the bone curves. Then when there is a gap in between the air and bone curves, bone conduction being normal, we consider it as conductive hearing loss. Okay. The examples of conductive hearing loss are wax, meatal atresia, ocular dislocation. Okay. Criteria is the gap in between the two, that is the bone conduction and the air conduction, should be a minimum of 15 to 20 decibels. If it is less than 15 decibels, we do not consider it as conductive deafness. Coming to sensorineural hearing loss. In sensorineural hearing loss, the common pathway is affected. It's understood. What is affected? The cochlea or the nerves, or even behind it also the pathway in the brain also may be affected. All this will come under sensorineural pathway, sensory and neural pathway. Okay. So when the common pathway is affected, because the sound has to pass through the common pathway, both air and bone conduction will be decreased. Okay. And the air-bone gap is not more than 15 to 20 decibels. Suppose just we are going to talk about mixed hearing loss, but if the air conduction has fallen down, bone conduction has also fallen down, and there is a gap, then it becomes mixed hearing loss. That means in addition to the sensorineural component, there is a conductive component. Okay, just to differentiate. Okay, so in sensorineural pathway, sensorineural pathway is affected, what happens? The common pathway is affected. Because the common pathway is affected, the air conduction also has to pass through the bone conduction route. So there is a fall, or the thresholds of both the air conduction and the bone conductions have fallen down. Okay, so because of which in this case we have a downsloping audiogram. That means in the initial frequencies, both the air conduction and the bone conduction are almost like okay. The first one at 250 hertz is, yes, it has come down to 35, but the second one is at 20, that is normal. But as you go to the higher frequencies, the hearing loss is getting increased. This is called a downsloping audiogram. This is seen in POND. In presbycusis, ototoxicity, noise-induced hearing loss, we see downsloping. Also in acoustic neuroma. So this is an important from the NEET PG point of view. So they are going to ask you repeatedly, downsloping audiogram is seen in what? Very difficult to remember. So there is a mnemonic POND. Presbycusis, that is hearing loss associated with aging, ototoxicity, because of drugs, noise trauma, because of noise, because of high listening to long periods for a higher intensity for long periods of time, you will get noise trauma. You will see downsloping also in acoustic neuroma. Okay, but these three are important: presbycusis, ototoxicity, and noise-induced hearing loss, NIHL, noise-induced trauma. You see downsloping hearing. So the initial frequencies are good, but the later frequencies have got affected. What is upsloping? Upsloping, the later frequencies are normal, but the Initial frequencies 250, 500, 1000 and 2000 hertz have got affected. These have got affected. This is seen only in the early stages of Meniere's disease. Early stages of Meniere's disease. In later stages, it will become a flat audiogram. Even the higher frequencies also will get affected. Okay, this is low frequencies are affected more, seen in early stages of Meniere's disease. So this is the only condition where you will see that the low frequencies are affected. Okay, now coming to the next slide. U-shaped or trough-shaped. U-shaped or trough-shaped or cookie bite, we call this U-shaped trough cookie bite. The low frequencies are fine, the higher frequencies are also fine, but the middle frequencies have got affected. Okay, this is seen in congenital hearing loss and cochlear otosclerosis. Congenital hearing loss and cochlear otosclerosis. So this is quite rare. Both of them are very rare conditions. Good perception in high and low frequencies, but difficult to follow a conversation. Why? Because these are the speech frequencies. Speech frequencies are 500, 1000 and 2000 hertz. Okay. Now coming to another important question from the NEET PG, and also quite we get confused. Acoustic dip and Carhart's notch. Acoustic dip is seen in noise trauma. Carhart's notch is seen in otosclerosis. In acoustic dip, there is a dip in both air conduction and bone conduction curves. There is a dip in both air conduction and bone conduction curves. Okay, at 4000 hertz. At 4000 hertz. So acoustic dip is seen in noise induced hearing loss, where there is a damage to the hair cells of the cochlea. And so because the cochlea is getting affected, what does it mean? The sensorineural pathway has got affected. When the sensorineural pathway has got affected, what happens? Air conduction and bone conduction both are affected. That is what we saw in sensorineural hearing loss. Okay, so there is a dip, characteristic dip at 4000 hertz only. So this is seen in noise-induced hearing loss, early stages. Carhart's notch is seen in otosclerosis. In otosclerosis, what happens? There is a growing of this otospongiotic bone on the stapes foot plate. Okay, in that there is a dip only in the bone conduction curve, only in the bone conduction curve. So you will get confused. Okay, otosclerosis is basically a pathology of the conductive pathway. Then why is the bone conduction curve getting affected? Because bone conduction curve is getting affected because nothing is happening to the cochlea at this stage. The reason postulated is, if we are not sure, but the reason postulated is the stapes is responsible, has a resonance of the sound. We saw this in physiology of hearing. Each part of the ear has a specific resonance, and that preferentially increases the sound when such frequency is presented to the ear. So they say that the stapes has a resonance of 2000 hertz. So when stapes is not able to function at its best, so then there will be a bone conduction dip, only a bone conduction dip at 2000 hertz, which gets corrected once you do a successful stapedectomy. This will become normal. Okay, so Carhart's notch is seen in otosclerosis, where there is a dip only in the bone conduction curve. Carhart's notch is seen in otosclerosis, where there is a dip only in the bone conduction curve at 2000 hertz. Okay. So because this is quite confusing, so I just made a small chart. So acoustic dip is seen in noise trauma, Carhart's notch is seen in otosclerosis. Acoustic dip, there is a dip in both air conduction and bone conduction curve seen at 4000 hertz. Carhart's notch, there is a dip only in bone conduction seen at 2000 hertz. From here, this is a mnemonic, how to remember. Okay, acoustic means noise. So noise, acoustic noise is seen in noise-induced hearing loss. Carhart's is the name of a scientist who discovered this characteristic dip in bone conduction. So otosclerosis, you can connect this Carhart's notch to otosclerosis, the scientist who discovered this dip. What is the pathology here? As we said, the hair cells of the cochlea are getting affected because that is a common pathway. Both air conduction and bone conduction are getting affected. Pathology here, there is a foot plate of the stapes, there is otospongiotic bone. Stapes has a resonance of 2000 hertz. So there is a dip only in bone conduction. Can this be cured? Can this 4000 hertz dip be reversed? It is not possible to reverse. Can this bone conduction be reversed? Yes, it can be reversed. It can be reversed after a successful stapedectomy. Coming to mixed hearing loss. Here, air conduction and bone conduction are affected. There is a defect in the common sensorineural pathway, and there is also a defect in the air conduction pathway. Okay, middle ear, or even in the external canal also may be affected. Something is there, some pathology is there. But in addition to that, air conduction is much more decreased compared with bone conduction, because of which there is an additional bone gap is present. See, this is an example. 20 is considered normal, the bone conduction has fallen down from 30-35 decibels approximately. At this range, it has fallen down 40-35-40 decibels, the hearing loss. Again, which means sensorineural pathway is not normal. Bone conduction is not normal. There is a problem with the sensorineural pathway. If you see the bone conduction curve has fallen down, you first think, yeah, there is a problem with the sensorineural pathway. Now, in addition to that, there is a gap, more than 15 decibels gap. That means the air conduction also there is a pathology. Okay, so there is a pathology in the sensorineural pathway and there is a pathology in the conductive pathway. This is seen in unsafe CSOM, otosclerosis with cochlear involvement. So what is unsafe CSOM? What happens in unsafe CSOM? There is cholesteatoma. What is cholesteatoma doing? It is damaging the bone. When it is nibbling away at the malleus, incus and stapes, you will have a conductive hearing loss. In addition to this, the toxins that are released when this bone is getting damaged or when the bone is being eaten or nibbled away, what happens? There is this toxins that are going through the round window or the oval window, and they affect the cochlea also, hair cells of the cochlea. So then you will have a cochlear involvement. So here there is sensorineural involvement and the involvement of the various bones, malleus, incus and stapes, ossicles. Then you will have unsafe CSOM. Otosclerosis with cochlear involvement, again same kind of pathology. Otosclerosis, you have this otospongiotic bony focus at the stapes, and those toxins will go into the cochlea and damage the hair cells of the cochlea. So here basically these two things are basically what they are conductive pathologies. But you may also have a cochlear involvement component, though it is not seen in every case, but otosclerosis with cochlear involvement is rare. Unsafe CSOM with cochlear involvement is not so rare, but we think of CSOM, we think, okay, there is conductive pathology. But when you do a Pureton audiometry, there will be a slight decrease in the bone conduction pathway. Then you say, okay, yeah, there is a bone conduction has got affected, sensorineural pathway has got affected. So you counsel the patient. Why is all this important? Because you counsel the patient saying that, okay, I am going to operate on this case. I am going to remove the cholesteatoma, give you a safe ear, but I cannot give you any guarantee, sir. Your hearing will become totally normal. If you tell the patient beforehand, they will be prepared for it. Otherwise, there may be, even a lawsuit. Okay, what is high frequency audiometry? So, conventional audiometry, we were testing what, 250 to 8000 hertz. When you test above 8000 to 20,000 hertz, okay, this is called high frequency audiometry. What is the purpose of doing this? It is observed that when you give this, what is this, streptomycin, such kind of cochlear toxic drugs, cisplatin, these are cochlear toxic drugs, and you give to the patients. In the initial stages, you take a baseline Pureton audiogram, and you start from the first dose itself, you start repeating the Pureton audiogram. And you start seeing that there is a loss of the high frequency, there is a loss at high frequency levels, more than 8000 to 20,000 hertz. That means that this patient is starting to develop sensorineural hearing loss, okay, ototoxicity. This is called early ototoxicity. The benefit of it is 8000 to 20,000 hertz, no one is actually hearing anything. Okay, we don't need these frequencies for day-to-day conversation. But we need 500 to 2000 for daily conversation. So nothing is going to happen when you lose 8000 hertz or 10,000 hertz. It's not that we want to lose, but not so much damage occurs. So in the initial stages only, if you can take a baseline Pureton audiogram and then keep repeating the Pureton audiogram, and you start seeing that, okay, probably 12,500, there's a dip. Okay, this patient is starting to develop ototoxicity. Let us stop the ototoxic drug. Okay, so you can save the speech frequencies. Same thing with noise-induced hearing loss. In a factory setting, the loud sound is there, and the patient and the person is working there. Initially, there is a baseline Pureton audiogram, and then they start repeating. And then once they start seeing that the high frequencies are getting affected, then you say that, okay, in the future, if you continue the same thing, patient is start going to develop the affecting of the speech frequencies. So you stop at that point, or you ask him to shift him to another part of the factory, take some, remedial measures. So this Pureton audiogram, I have just put it to say that, okay, at 20 to 29 years, even all the frequencies are properly heard. Even the later frequencies are heard. But when the person comes to 50 to 60 years, there is a dip. after 12,000 to 18,000 there is a dip. Okay, so the frequencies are getting affected. Not that presbycusis cannot be stopped. There is nothing you can do. This is hearing loss associated with aging. Even if you detect high frequency hearing loss at 50 to 60 years, what can you do? Nothing. Okay, so this is useful mainly in early ototoxicity and noise induced hearing loss. So this definitely has a role in those two settings. Thank you for watching. If you like the content, please like, comment, share and subscribe.